In this video, we are going to discuss about acute and transient psychotic disorders. It's a bit confusing concept, so we try to understand this by using our reference as Marneros. So I've tried to explain acute and transient psychotic disorder in form of this short animation. I hope you like it.
Imagine a psychiatric disorder that arrives like a lightning strike, explodes into drama, and sometimes vanishes just as fast. Welcome to Acute and Transient Psychotic Disorders, Psychiatry's equivalent of a sudden summer storm.
In ICD-10, ATPD refers to psychotic syndromes with acute onset, typically within 2 weeks, polymorphic or changing symptoms, associated with stress, and usually a full recovery. We're not the first to notice these fast-onset psychoses. Let's see what past psychiatrists thought. For example, Legrain in 1890 defined bouffée délirante, a French word in English, as an illness with sudden onset plus full recovery. Boom, gone.
Legrain defined a concept which is called as bouffée délirante. It means that the psychosis just comes like a bolt from the blue. You'll have unclouding of the consciousness. You'll also start hearing voices which other people do not hear. You'll start seeing things which other people do not see, and perhaps you'll have false, fixed, unshakable beliefs which other people do not have. The delusions are hallucination. And just like it comes, it goes like that. And according to Legrain, many such episodes could happen in a lifetime because those things were not very well studied. And then Langfeld came with the concept which is called as process schizophrenia. So what is this process schizophrenia? Process schizophrenia is the illness, the psychotic illness, which does not get materialized into the actual schizophrenia. The actual schizophrenia where you will always get worse and you will never improve. That was the understanding at that time.
Phreniform psychosis, short illness, feverish vibes, then recovery. By shock therapy. Kleist described Cycloid psychosis, or cycloid psychosis, is a dramatic, rapidly shifting, phasic illness that swings between states like confusion, anxiety, euphoria, or motor agitation, stupor, yet often ends with a full return to baseline and few long-term deficits. Thought to arise more from perinatal brain vulnerabilities than genetic loading, it behaves like a quirky cousin of affective and psychotic disorders, common in women, especially postpartum, and demanding careful antipsychotic use due to higher catatonia and neuroleptic risk.
Cycloid psychosis was a phasic kind of psychosis, a phasic kind of schizophrenia, which comes and goes. So please understand that there are some psychiatrists which believe that once there's a psychosis, there's an insult to the brain and it will eventually progress to schizophrenia. But there are some psychiatrists which do believe that if there's an insult to the brain, it might not progress to the schizophrenia. So there were some of the classification, like for example, the cycloid psychosis had various other categories. One of them was motility psychosis, then there was anxiety blissfulness psychosis, and then it was also confusional psychosis.
Reactive psychosis is a sudden, trauma-triggered psychotic break where the delusions and emotions symbolically mirror the psychological blow. Jaspers saw it as understandable madness born from meaning. But as later studies showed many cases drifting into schizophrenia or mood disorders, enthusiasm faded, replaced by modern ideas of stress vulnerability and the rise of PTSD as the dominant trauma-linked diagnosis.
Jaspers always believed that there's a stress, and this leads to all the components of the psychosis. But then there were some other psychiatrists. They believe that there might be an entity which might not have the stress as a precipitating factor, or like they might have, but they might not have the affective component as a precipitating factor. For example, they had another category of psychosis which is called as non-affective remitting psychosis, or NARP. So there's no general criteria for NARP, so we have to summarize criteria from different kind of classificatory system, and the general agreement is that the psychosis, which develops within 72 hours of the insult, there's no affective symptoms. It's not because of substance use, and there's no marked mood syndrome. There's no negative symptoms, and it has led to like acute functional disruption.
Hollander and Hirsch's hysterical psychosis was a rapid-fire, emotionally explosive, trauma-linked psychotic storm that appeared suddenly, vanished just as dramatically, and was often seen in people with histrionic traits rather than classic schizophrenia features. Modern systems no longer use the term, but its clinical picture survives inside today's brief psychotic disorder and ICD's acute and transient psychotic disorders, both capturing the same sudden onset, short duration, full recovery pattern.
So we have divided the acute psychotic presentation into various parts. If it's after the trauma, perhaps the psychological trauma, then it is NARP, but it doesn't have to be very colorful. It doesn't have to be, having a lot of effect. If it lasts from 1 day to 1 month, then it becomes brief psychotic disorder. And if it is for just 2 days, perhaps 48 hours, and it starts improving, then it's cycloid psychosis. And then if it is like less than 2 weeks, it's brimming like that, and then it starts improving, then it's acute and transient psychotic disorder, like in ICD-10 or ICD-11 as well. There are also certain questions, especially regarding the psychosis. What happens if you get it once? Will it happen again? So there was no single answer, so we just brought the evidence to get a better answer for this. For example, there were some free field trials by Jorgensen, and they said that 3 out of 10 or 4 out of 10 individuals, they'll get it again in 3 years. And some people even believe that people will have these episodes and then they will be absolutely normal till baseline. Then they'll again have these episodes and they'll be absolutely normal till the baseline. And according to the British Journal of Psychiatry, 50% of ATPD patients had at least one recurrence. And if there are 2 episodes, you should think about schizophrenia. That's what some of the psychiatrists do say, and most of the evidence points towards it. Like, for example, the general NHS data says that 25 to 50 out of 100 individuals will shift to schizophrenia over the years. Perhaps there's a damage to the brain once, and then it might progress to a kind of schizophrenia where there might be an evidence of neurodegeneration. And some, if it's too many mood symptoms, some might even get into bipolar affective disorder. There are some categories in ICD-10, the acute and transient psychotic disorders, acute polymorphic psychotic disorders without symptoms of schizophrenia, acute polymorphic psychotic disorder with symptoms of schizophrenia, acute schizophrenia-like psychotic disorder, other acute predominantly delusional psychotic disorders, other acute and transient psychotic disorders, and acute and transient psychotic disorders which are not specified. ICD-11 has just 4 categories. The sections or codes: acute and transient psychotic disorders, first episode, multiple episodes, other acute and transient psychotic disorder, and acute and transient psychotic disorder unspecified. DSM-5 still holds on to its classificatory system. Number 1, it says that either a person can have brief psychotic episode, brief psychotic disorder, then they can have acute schizophreniform psychosis, and if it progresses more than 6 months, then it becomes schizophrenia. Well, thank you so much for patiently watching this video. I hope this might have clarified your concepts about acute and transient psychotic disorder. And please don't forget to subscribe our YouTube channel. And please don't forget to go to our website and obviously buy our course. Well, thank you so much for patiently listening to us.